Hello, I'm Geraldine Moses. Welcome to this program on Juvenile Idiopathic Arthritis, Clinical Guideline for Diagnosis and Management. The program is one of 4 in a new musculoskeletal guideline series. These guidelines for general practitioners and other primary care health professionals have been developed by the Royal Australian College of General Practitioners and approved by the National Health and Medical Research Council. Because of the relatively low prevalence of JIA in the general population, GPs often have little experience with this diagnosis. The guidelines have been developed, therefore, to fill that gap and reflect the current evidence-based approach to managing children with JIA. So this program will cover the recommendations for the early and accurate diagnosis and multidisciplinary management of JIA in the primary care setting. You'll find a number of useful resources available on the Rural Health Education Foundation's website. That's www.rhef.com.au. So now let's meet our panel. Firstly, Dr. Morton Rowland. He's a general practitioner in Victoria and has worked in rural and metropolitan practice. He is Vice President of the RACGP. He was a member of the JIA working group for the development of this clinical guideline we'll be talking about tonight. Welcome, Morton.
Thank you.
Dr. Jeffrey Chato is a paediatric rheumatologist and head of the Department of Rheumatology at the Children's Hospital Westmead in New South Wales. He practices both through the hospital and in private practice on Sydney's North Shore, and as well has recently been commencing a paediatric rheumatology clinic at the John Hunter Hospital in Newcastle. He was also a member of the JIA working group for the development of the clinical guidelines. Welcome, Jeff.
Thanks.
Penny Barham is an occupational therapist who's been working in paediatrics for nearly 30 years. She currently works with both the Queensland Education Department and Montrose Access as part of the outreach team to the Darling Downs region in southwestern Queensland. She works with special needs children, including those with JIA. Welcome, Penny.
Thank you.
Karen Felicamo is the Chief Executive of Arthritis New South Wales. Karen has nearly 20 years' experience working in senior management within the health system in areas including health promotion, community participation and palliative care. Welcome, Karen.
Thank you.
And finally, Kerry West. She's currently Deputy Head Physiotherapist of the Children's Hospital at Westmead. She has extensive experience working clinically as a paediatric physiotherapist, especially with children with arthritis. Welcome to you all.
Thank you.
So let's start the program with our first case study, which involves 2 young people. The first one is Priscilla, she's aged 25, and the other is Peter, he's aged 19. And they both talk about their different experiences growing up with JIA.
My name's Priscilla Richardson, I'm 25. I've had juvenile arthritis since I was 18 months old. I've got arthritis in every bone in my body, so therefore I have good days where I can do nearly anything, and then other days I have really bad days where I'll find it hard to walk around or whatever. And in the past it's been really bad that I've had to get both my hips replaced and both my knees because I just couldn't take the pain or anything anymore.
I'm Peter Reid, I'm 19 years old. I first had problems with my hips when I was about 10 years old, and the doctors didn't know what it was. Like each time I saw a different doctor, they said something different, like growing pains and other things. And so I went into hospital because I wanted to know an answer. I was in there for about a month at Westmead Children's, and they first they thought it was osteomyelitis, then they found it was arthritis, and first diagnosed in my left hip, and then a couple of years later I was diagnosed in the right as well, and I had a hard time with that.
At school I got teased a lot because my arthritis would change shapes of my body. Like I developed scoliosis in my back and then also developed a swayed back, which didn't help at all. And doing PE for school, everyone got to join in and do their activities, and I couldn't do it, so therefore I had to like sit on the sideline and always felt left out. Found it very hard to make friends because I was always getting teased due to my arthritis.
I was playing first grade soccer as a goalkeeper and then just couldn't keep up with everyone else, and so I was on the sidelines for most of the games, and so like saddens you a bit, especially when you're younger, that you can't keep up with everyone else or do what everyone else can.
Some days it's hard just like cutting or holding cutlery or even cups or just doing the simplest things. So every day brings a new experience, I guess.
And these young people with arthritis. Now, Jeff, if we could go to you first, please. How typical are these stories?
I think they're not so much typical in that they're not identical stories, and therefore they illustrate a spectrum or a range of the severity of juvenile arthritis. And as we are discussing, and as is listed in the guidelines, there are different types of juvenile arthritis, some of which are very severe, like Priscilla's, in which they start as young children, high fevers, systemically very unwell, so-called Still's disease or the systemic onset group, and they may need quite intensive therapy or very intensive therapy, fancy new drugs, immunosuppressive therapy to maintain the disease. And then there is disease that might affect one or two larger joints. They might start as an adolescent like Peter did. They might have the HLA-B27 gene, and often the inflammation is thought to be infection to start with. They're thought to have had a septic hip or a septic sacroiliac joint. It becomes clear with persistence of their symptoms, with morning stiffness, that this is an inflammatory and not an infective process.
So there's a wide spectrum of the disease, which means we're going to be struggling with definitions here, I think. So perhaps for the benefit of our viewers, can you please define what is JIA for us? Okay,
that's being very clearly defined, so that part's fairly easy. Juvenile, meaning that you're less than 16 years of age when you first get your disease. Idiopathic, that medicalised term, which means we don't really know the cause of it and it's not part of another disease process. And arthritis, meaning you have inflamed joints. So by definition, the joint needs to be swollen, it needs to have limited range of movement, and needs to have pain when you move the joint.
Now, I notice you're not saying juvenile rheumatoid arthritis, which is a term that people often use. So perhaps we need to clear up that as well, this terminology. Why is it not called juvenile rheumatoid arthritis anymore?
So historically, in 1977, when a nomenclature group first got together, juvenile rheumatoid arthritis was the term used as thinking that these were young children who had rheumatoid arthritis. It's very clear then, in fact it was very clear 100 years before then when Stills first described it, that these were not children with an adult disease. These were juveniles who had arthritis, and only a small group of those children, which are mostly the adolescent girls, have positive rheumatoid factor and have an adult type disease. The others are either juvenile idiopathic arthritis or JIA, which is the commonly used term, and along the way there was a JCA, just to further confuse the issue, which was juvenile chronic arthritis, which has been dispensed of as well.
Right. And Still's disease, what's the terminology, the other terminology for that?
Okay, so George Frederick Still, who we think of as the grandfather of paediatric rheumatology 100 years previously, had described a group of children with high fevers, rash, very unwell, joint deformities, and that's the group that we now call systemic onset juvenile arthritis.
And all this terminology, is it outlined in the guidelines?
It's outlined in the guidelines. It's available on many of the standard websites and many of the standard text.
Terrific.
And it's more important for targeting management and outcome measures than it is of making the diagnosis.
There's a picture of the guidelines on people's screens right now, and it can be accessed, as you say, through many websites, particularly through the RACGP. So perhaps some more definitions. What's the prevalence of JIA in the community?
So the best data we've got is that somewhere between about 1 and 4 per thousand children are affected. There's been some local data from Western Australia, but there's been no registry to confirm that. But across the world it seems to be fairly similar to the incidence of diabetes in childhood.
So, and the prevalence in Australia, is it about the same as other countries?
We think so, the other Western countries,
right.
Yes.
And do you think there's any predominance with different ethnic groups at all?
There is. We don't have data on that. And even within immune inflammatory disease, we know, for instance, that lupus is much more prevalent amongst our Asian population, either living in Australia and certainly those from Asia. It's more prevalent amongst the Negroes in America, it's more prevalent amongst the blacks, indigenous in Australia, so there is quite a disparity across cultural groups.
Right, and so do we have any idea what, well, I guess because it's called idiopathic arthritis, we don't really know the cause, but what's the possible pathology that lies behind this autoimmune inflammatory disease? So
there have been lots of postulates in terms of having I suppose a fertile field or receptive genetic predisposition, and then something may trigger that. And there have been theories about infectious triggers, because we know you can get a reactive arthritis. We know that you can have gastroenteritis and you can have swollen joints afterwards. And that tends to be this group that are HLA-B27 positive, but the reality is no, we don't know the cause of arthritis in children or in adults.
No obvious genetic link for the juvenile form of arthritis.
There are some risk genetic profiles, but there's no very strong link.
Right. And what would you say then is the difference between juvenile idiopathic arthritis and the adult version of the disease then? Are they the same disease?
No, they're not the same disease, except for that small subgroup, which are the children, adolescent girls, positive rheumatoid factor, what we would call polyarticular seropositive disease. So they've got rheumatoid factor and they really are a juvenile who has rheumatoid arthritis. But for the vast majority, the other 90–95%, they're children with swollen, inflamed joints, but not with an adult type disease process.
Perhaps if I can just ask Karen a quick question. Karen, you're from Arthritis New South Wales and you speak to a lot of, well, you and your organisation speak to a lot of people with dealing with arthritis. Do you get people saying that children don't get arthritis?
Definitely. That's one of our greatest battles actually, because everyone just thinks of arthritis as being an older person's condition, and we've been making a lot of effort in the last 12 months to really get the message out there that children get arthritis too. So yes, and sometimes for parents they can be quite bewildered when they're told that their child's diagnosis is arthritis, because parents think that too, but gosh, that's an older person's condition. How can my child have arthritis? So yes, it can be really scary for parents. They don't know what the future holds for their child.
Absolutely. So now to our first case study. Jack is a 15-month-old infant whose mother has brought him in to see her GP in a country town. She says that he's not been himself for some weeks and now thinks that he may be suffering from a virus because he has a fever. He's not eating well and he's lost weight. He has skin rashes and is not walking like he used to and appears to be in pain. Now, Morton, if I can turn to you for this, so you're the GP that brings this child in. What would be the things running through your mind as a possible diagnosis with these symptoms?
Look, I think that there could be quite a few things going on here. I think certainly the infective viruses, some of the other traumatic things, but I mean it appears to be an acute inflammatory process going on with this child. You do need to think about juvenile idiopathic arthritis in this setting. It's not common, but you know, if you don't think about it, you're not going to find it.
That's a tricky thing, isn't it?
Absolutely.
And I guess then you turn to the guidelines.
Indeed. And they are there.
So we actually have a photo of the algorithm for diagnosis of JIA to show you what it might look like. But what would you say are some of the first things you should do? I suppose it would be examining the patient?
I think the classic things that you do with any patient, you take a good history.
Right.
You know, you make sure that you're covering the bases. Then you do a full examination of the patient, and particularly the joints that are appearing not to work particularly well. Looking for signs that might be in the differential diagnosis. You know, is this child possibly of an Indigenous background that might be exposed to, for instance, rheumatic fever, or perhaps, you know, looking at you know, another viral cause. It's been going for 3 weeks. It's a little bit long.
So in terms of, so you take a history, in terms of examination, what are the things you particularly focus on?
Well, I think from a general practice's point of view, you need to look for synovitis and swelling of the joint if you can possibly do that. Look at their fever, their systemic symptoms, and just actually watch them walk or do what they do. In a young child like this, ask mum. Okay.
I was going to say, I mean, they're so young, they might be able to say, goodness, my joint feels stiff.
That's right. Yeah, I think it's, take mum's word for it. And I mean, being in rural practice, you often see these children when they're well, you know, when you were first looking after them. This child has obviously changed.
Are there other things in the differential diagnosis that we need to be thinking about? I guess there's all the other autoimmune inflammatory conditions as well as infections.
Sure, there certainly is, and I mean, I think that it depends a little on the age groups that you're looking at. In the guidelines, there is a good section on differential diagnoses, but the key thing, I think, is just to bear in mind that JIA might be a possibility.
Are there any blood tests that you do?
Having thought about whether this might be the case, yeah, there are blood tests. A full blood count, looking for inflammation in the blood with an ESR and a C-reactive protein. If you do believe that there may be a possibility of JIA, you need to look for their rheumatoid factor and look at HLA-B27 as a marker. You may even do a plain X-ray of their joints, but you know, it depends on what is available in your locality.
I was going to say, do you have access to all those blood tests as well in a rural location?
Most of those blood tests are pretty ubiquitous everywhere.
So if your suspicions are mounting that it might be JIA, at what point do you refer to a rheumatologist?
I think if you truly believe that it is JIA, I'd certainly be on the phone to my friendly neighbourhood paediatric rheumatologist and ask an opinion and look to see whether there were other tests that could be done in your local area to save the patient travel, and then with the whole package they see the paediatric rheumatologist.
Yeah. Now, Jeff, do you have any comments there about getting to you in a timely fashion?
Always available. I think a couple of things. Infection, inflammation. Young child, unexplained fever, weight loss, malignancy always comes into it, so that's in the differential. Even in bigger kids who are presenting with bone pain rather than joint pain, just bear that in mind, and sometimes the plain X-ray would be helpful along that line. Yeah, look, I think if geographically the paediatric rheumatology practice or hospital is not accessible, the phone always is, or emails always are, or leaving messages and getting back, you know, the doctor getting back to you if they're not in the practice at the time. I think a 5-minute chat may save the child a lot of unnecessary investigations and may target where to go more quickly.
Do people send you photos of the child maybe to demonstrate the swelling of the joints and so on? That's happening
increasingly, not so much joint swelling but unusual rashes, vasculitic, inflammatory rashes, easy to email pictures, and yes, certainly pictures of the child will often, you know, jolt you into action more quickly, saying, look, this kid needs to be seen very soon, or nothing about that looks worrying, why don't we get this other test done first?
Now, we had a question emailed in from a clinician in far north Queensland who was concerned about misdiagnosis of acute rheumatic fever by doctors thinking it was JIA, and these children with this infection were being treated with drugs for arthritis and then getting worse. So are there any particular tests we can guide our viewers or examinations that they can do to be more clear about the diagnosis, to exclude acute rheumatic fever?
Sure. It's not so much tests, it's clinical pictures and patterns. In our population groups, the incidence and prevalence of these two diseases is really quite disparate. Australian Caucasian children getting acute rheumatic fever, extremely uncommon.
Right.
Indigenous population, a much more common scenario. Age groups, rheumatic fever often a school type age group, you know, 5 to 10 sort of ages. The very young child, high fever and a rash at 15 months, not going to be rheumatic fever. Rheumatic fever, the joint swelling moves around, so the so-called flitting arthritis. It may be a knee for a few days and it may be an elbow a few days later. Inflammatory arthritis, it tends to be the same joint staying inflamed for some time until they're treated. Fever patterns, the duration of fever, and obviously cardiac involvement. If we go right back to the Duckett-Jones criteria in which he described all the criteria for rheumatic fever, then there are major and minor criteria, and cardiac involvement, as in valvular disease, is not really a feature of systemic onset juvenile arthritis, although pericardial effusions, fluid around the heart, and pleural effusions may be a feature of that. So I think without necessarily getting antibodies to streptococcus, the ASOT, you can tell from the clinical picture in most cases.
What would you say then, for GPs watching this program, is the most common presentation of JIA in general practice? What sort of age, the gender?
So going through the 7 subgroups, which I don't necessarily have to go through here, but the group that stands out most commonly numerically is the so-called oligoarthritis, meaning a few joints, and by definition 4 or fewer joints. They typically affect young girls, meaning 2, 3, 4-year-olds. I think of it as the knee at 3, so it's a little 2 or 3-year-old girl with a swollen knee, morning stiffness, limping, otherwise well in herself.
Right.
and that's about 40% of the new presentations of juvenile arthritis in most big series.
And all these subtypes of JIA, are they all outlined in the guidelines now?
They are. They're listed in the guidelines, and in fact, because they differ in their severity and presentation, there are management guidelines particular to the subtypes as well.
Are they very relevant in general practice, really, for professionals or even for patients themselves to know that they're a particular kind of JIA?
I think they're relevant to give prognosis to the family. When you first come, you can tell them, look, this is quite severe, I think you're going to end up on much stronger disease-modifying drugs, or look, that's a single joint involvement, I'll speak to my colleague, but often I found with these kids that a simple steroid joint injection will settle it down very quickly and the long term is good.
Right, now I'd like to ask Karen again about the role of family in all of this. Say we've got a case like this little infant, it's going to drive the parents crazy. They're going to be so worried, and hopefully they'll know to get onto an organisation like yours. So what are the things that people ask about, and what do parents need at this point?
Parents need an early diagnosis. That's the most important thing, and I can't emphasise that enough, because often that will mark the pattern for how the child actually progresses with their condition. Once they have an early diagnosis and they know that it is a form of arthritis, then they can contact an arthritis organisation in their state. There is one in every state of Australia, including the Northern Territory, and we can actually put them in touch with other parents who are in a similar situation. We know that parents want to know, as I mentioned, what the future is, what's going to be the development for their child, so we can put them in touch with parents and also with other children. And the other thing is, you mentioned families, it's also really important that the other children, that the siblings of the child with arthritis understand what's going on as well, because it affects the whole family basically. But we offer education, awareness raising, we offer a camp, which I think we'll talk about a little bit later. But yes, we can probably take some of the mystery away from the situation that the family are going through.
So actually I'd like to go to Penny now, and maybe you can tell us a little bit about what is the role of multidisciplinary care, because the guidelines do emphasise that that's something we've got to guide people to, where it wasn't so much done in the past. What's the importance of multidisciplinary care?
Well, it's most, from the OT's point of view, it's about how they're coping at home and with their everyday life and at school, and problem solving so that they can lead a more independent life and participate in things at school and be generally able to participate in everything that's going on in their, and not feeling like they're left out like they did in the movie.
Yeah, so what would be some of the things that you'd help the parents with, say with this young child? Would you help families like this as an OT?
Yes, we'd come in and see what the major problems were, the real problems, not the imagined ones and not protected. We'd just try and help them to be really independent, like giving them bigger tools to work with. How old is he? 15 months. We wouldn't start with pens and pencils at that age. We'd just see that they can actually move around and play with normal things and generally run around.
Right. Did you want to elaborate on what you meant about the imagined problems?
Well, sometimes when people are told they have arthritis, they think that they have to keep, or they feel that they stiffen up, or they can't move, or so they tend to overprotect them instead of letting them join in or just be normal and run around and do
well, perhaps
everyday
at
things.
that point we could ask Kerry, clearly there's no role for bed rest here in the management of paediatric arthritis, so you're a physio. What would you be saying to these people, or indeed children with parents with young children with JIA?
Yeah, keeping moving is the most important thing, and if it's too painful to move on land, we might use water therapy, hydrotherapy, as a nice environment where the child can still be moving and not in pain from the joint inflammation. But I mean, really, in this sort of, as long as the diagnosis is early and they've started on quite aggressive medical management, more and more with these young ones, we're actually seeing there's less of a role for physio and OT because they're well managed medically. So more and more I'm not seeing them at these young ages because they're being well managed.
Jeff, if we could go back to you, what would you say? I mean, in the past with inflammatory arthritis, it was all about getting people out of pain. But what would you say we're looking at now with goals of therapy?
Really, the goals of therapy now is disease remission. I mean, what we're looking for is not, fewer active joints. We're looking at no active joints. Now, clearly one needs to titrate that against potential side effects of aggressive therapy. So sometimes if the patient is not tolerating their drugs, or you've got to what you think is the maximum level of drugs, you're still using pain relief to dampen the inflammation. But overall, if you take the active joints and if you inject them with a long-acting steroid, which we do under intravenous sedation, that settles inflammation, the swelling down that joint. And that's why Kerry said she's almost out of a job, because those joints no longer have contractions. They now move freely because the swelling has settled down. And then she can work to build up the muscles, but at least she's got a joint that moves normally and doesn't need casting and the things we used to have to do. And then we have the non-steroidal anti-inflammatory drugs, which will have been initiated by the general practitioner when they first see the patient to control the pain and swelling. But they do the best job they can, but that's not good enough at suppressing the disease. And then depending on the disease type, we step up to disease-modifying drugs, of which methotrexate is pretty much the standard in paediatric rheumatology at the moment, and salazoparine or sulfasalazine is used as well. And then we have the new, perhaps not wonder drugs, but the biologic drugs, which are specifically targeted against inflammatory molecules, and have been very effective, although expensive, have been very effective at switching off active disease and not ending up with children, as we saw, like Priscilla, stunted growth, joint deformities, and great disability.
We'll elaborate on the drugs in a moment, but just before we leave the discussion about multidisciplinary care, I just was wondering, we have an occupational therapist, we have a physiotherapist and the support group. Who's in charge of making sure patients with JIA and their families are referred to these health professionals, Jeff?
Well, the original source of referral is the general practitioner.
Right.
The patients themselves are taking a very active role now by themselves contacting support groups, other parents and Arthritis Foundation type organisations, and so they may be driving and they may come and say, but do I need to see a physiotherapist, or have his eyes been checked? They may go through their own checklist. But overall, sure, there is a team, but yes, someone needs to be guiding the team.
Right.
And I mean, I would say here that these type of patients are really very good for a team care arrangement plan, GP management plan type activities in general practice. And certainly, you know, I think the other thing to stress is, from a general practice point of view, is don't forget good old paracetamol on a regular basis in the acute phases of this. That can really make a difference.
Well, we'll come back to the drugs, but would you say then the treatment plan itself, is that managed by you, or is it devised? Who devises it and who looks after it?
Well, I think that the GP has overall sight of what's happening with this patient, because there are a lot of people who are going to be involved. It does need some coordination. Again, it depends a little on the severity of the disease as to what diseases are involved, what joints are involved, as to who's working at what. But if the GP is seeing the patient and the family all the time for other things as well, they're in a perfect position to coordinate and make sure that things aren't missed.
And given that the infant in our case had a rash and it's suggestive of perhaps more severe disease, sure. Is it the GP's responsibility to ensure regular monitoring of the systemic manifestations of the arthritis? I think
that's it's a joint in these sort of more severe cases. It's joint responsibility with the paediatric rheumatologist, working very closely so that we both know we're on the same page.
Right. Well, we have another case study now. A little girl, Imogen, who's 5 years old. She was diagnosed with oligoarticular JIA when she was 3. Her joint disease was well controlled with local steroid injections to her left knee and her right ankle on 2 separate occasions. She has, however, had troublesome uveitis detected on a recent ophthalmological review. So, Jeff, the issue of uveitis, it's such a big deal with inflammatory arthritis. So can you tell me about what needs to be done in this situation?
So the uveitis is something that is more prevalent in certain of the subtypes, but essentially any child newly diagnosed juvenile arthritis should go to an ophthalmologist and have an initial slit lamp eye examination to see if they have some because some of them have inflammatory eye disease at the time of their presentation. And then they stratified according to risk as to how often they need to see the ophthalmologist according to the risk of the uveitis developing. And here I must stress we're talking about this low-grade, smouldering, asymptomatic uveitis. So it's not to say eyes normal, come back if they get red. This is not that disease. This is losing eyesight gradually if you're not right on top of things and watching for it. So they may need to go 3 monthly for several years to the ophthalmologist. And particularly this illustration, the young girl, swollen knee, easy to control joint disease. Her parents might think nothing else is going to happen. They need to be reinforced, regular visits to the eye doctor.
And this is all outlined in the guidelines
it's
as well?
Outlined in the guidelines. Excellent. As to how often they should go and who they should see and what the risk factors are.
Now, this little girl, she's very young, but what about things like monitoring her bone density? Is that important? It's
important much more so in children on steroids, which tend to be the more severe, so the systemic onset group. It's certainly important in anyone with inflammatory disease who's not mobile to think about their bone mineral density because they're not moving around. So the risk factors are high fevers and inflammation. That can make you osteoporotic. Being bedridden, that certainly can do that, but we've heard how we want to get the children up and mobile and in the pool and not bedridden. And certainly very cautiously titrating their steroid dosage to make sure that we've got more benefit than side effects.
So generally speaking, unless it's severe disease, what sort of comorbidities or complications would parents have to be monitoring over the long term?
So the eye disease we've spoken about, if joint disease is not controlled, you can sometimes get growth inequalities from one limb growing more than the other, or joint contractures, muscle wasting, loss of appetite, and then not to forget, I suppose, the social comorbidities that Karen mentioned. They want to be part of the group, they want to join in, they want to be accepted by their peers, and a lot of stress placed on the family. And then, as you said, later on we'll get into the side effects of the drugs, which is a separate issue.
Just specifically with uveitis, is there a chance, if she's the kind of patient, this 5-year-old girl, to have the smouldering uveitis, could it become acute?
It's not the worry that it'll become acute, it's the worry that she's going to progressively lose vision by the smouldering process, if you like, if it's not treated aggressively with immunosuppression or with steroid eye drops to stop the inflammation. The acute uveitis that people may be used to seeing in older people, that may be B27 related or so-called writer's disease, acute eye inflammation, that's okay because they present with a red sore eye. They don't have to get screened. They'll come when they have their symptoms. But that's a different subtype.
And they might not even know they've got inflammatory arthritis.
They may present with a uveitis, exactly right.
So I'm not sure what sort of medications that Imogen would be on for her JIA. She's got the low-grade one.
So initially when she saw her general practitioner, she would have gone on to a non-steroidal anti-inflammatory drug like naproxen to try and control the inflammation. And then if that wasn't working after a few weeks, she'd be best treated with intraarticular long-acting steroid into that joint to settle it down, and it'll do that for 6 months or longer after a single injection, targeted properly and given the right steroid. And then for the uveitis, she'd be on specific anti-inflammatory eye drops. She wouldn't need other disease-modifying drugs such as the methotrexate or the biologics.
With respect to just these analgesic medications, then would a general practitioner be administering the intraarticular steroids?
I think it depends on the GP and their relationship with their paediatric rheumatologist. There are GPs who do, but I would say that in these sort of cases most GPs would be doing it in conjunction with the rheumatologist, and particularly in young children it's a painful procedure, so often it needs to be done in an atmosphere where they can have some analgesia or perhaps even a neurolept anaesthesia occasionally for children to reduce the stress of the procedures. I'm
sure it hurts.
Yeah.
So we're talking a baseline paracetamol.
Yeah, the guidelines certainly would emphasise that young children under 10 or 12 should have intravenous sedation, anaesthesia, especially since it's likely to be a repetitive process and you want to stay friends.
How frequently in a year would a paediatric patient be allowed to have steroid injections?
The guidelines are not entirely specific of that because it's left up to the treating physician, but in general terms we would say any single joint could be injected 2 or 3 times in a year, but if there were multiple joints that were flaring at different times, that doesn't matter. You can do the other joints at other times because you've had your knee injected. It doesn't mean you can't have your wrist done a month later.
Now, Imogen's 5 in the original case scenario, but what would be the likely scenario when she's 12?
So Imogen's in a relatively good prognostic group from the joint point of view. So I like to say it's a disease that licks the joints but bites the eyes. So the joints one can control very easily, and she'll be running around normally and going to Camp Footloose and playing netball and climbing the rocks and doing all those ordinary 12-year-old things. The eye disease may be the driver of her morbidity, because sometimes that needs immunosuppressive therapy if that's not controlled. She may flare during her later childhood, so I've been in this long enough now to see the 3 and 4 and 5-year-olds turn 14 and 15 and present again with a swollen knee or wrist, and they might just ring, or their parents wouldn't, just say it's come back again several years later, but it still has a good outcome. You treat it again and it becomes controlled again with intraarticular steroids.
And so would you say to the family that this is going to be a waxing and waning condition over the years?
But a very treatable one, yes.
Right. Now, in terms of treatment, we've talked about baseline paracetamol, but then the drug we usually move to next, and it's all in the guidelines and is in the algorithm for drug treatment, is non-steroidal anti-inflammatory drugs. So what are the important clinical points that our viewers need to know about NSAIDs? Morton, would you like to talk about that?
Look, I mean, NSAIDs are often used in general practice. They're now available over the counter at the pharmacy. I think you have to guide the patient. It depends on their pain and their inflammation of their joints. Most people in the guidelines, it appears that naproxen has the most appropriate evidence at this point in time and the licence for it. In terms of NSAIDs, we need to be aware that it can give stomach problems, can give gastrointestinal side effects, and be aware. So, generally speaking, they're relatively safe drugs. Are
COX-2 antagonists used in children?
At the moment, there is no evidence, and they're certainly not licensed, as far as I'm aware, for use in JIA. But that's not to say that into the future that evidence may come.
And Jeff, would you say, I believe you use other NSAIDs beside naproxen, is that correct?
Yes, so a lot of it comes down to compliance issue. For the very young kids, ibuprofen and naproxen are the only two that are available as suspensions, although compound pharmacists we know will make anything into a suspension. But for ease of use, there's a soluble piroxicam, which can be just dissolved in water and given on a once daily basis, and that often helps compliance. And anything given, 12 hourly is more likely to be given than 3 times a day, in which the parents have to administer a school dosage. So they become and diclofenac or Voltaren would also be used with some frequency.
What about topical NSAIDs?
Very little data to support
Not
that.
helpful.
Yes, they, helpful because you're massaging the sore limb, but you may as well be using sorbeline cream to massage the sore limb. You don't get the penetration into the joint that people believe you do, so it doesn't have an anti-inflammatory effect on the joint itself.
Right. Do we worry about the risks that were associated with Vioxx and the reason why it was taken off the market? Do we worry about that at all with the use of, sometimes...
No, because in fact that wasn't a paediatric risk, it was adults with hypertension. So the children suffered by withdrawal of a good drug which is available as a suspension.
We miss it very much.
Yes.
It's Marissa Pillar from Queensland. She asks, is there any decrease in life expectancy in children started early on therapy? Jeff?
Okay, I presume she means by controlling the disease, do they live a normal life rather than is the therapy having an adverse effect? Maybe I'll answer both. Okay, so if her question historically related to children with very severe and untreated disease, in the time of George Frederick Still originally describing this, there was a significant mortality from sepsis, from being bedridden, from having bed sores, from all the things we can now prevent, and even relating to osteoporosis and crush fractures. If she's talking about does the therapy have long-term effects, the belief in that is no. although these new biologic drugs have only been around really 10 years in children, we're still following them. But in general, certainly when I talk to parents, I expect the children to live a normal life, get married, have children if that's still normal, but you know, a normal adult life expectancy.
So we also have a question from a nurse in New South Wales who asks, is there any connection with a young female infant being treated for a clicky hip to later developing any risk of JIA?
No.
Good. I guess it's more an orthopaedic.
I think what you're talking about is if you have a misdiagnosis of a dislocated hip, you end up with osteoarthritis in a hip that's not symmetric and not properly formed. Different condition from inflammatory arthritis.
And we also have a health professional in North Queensland asking, is there any connection between Ross River fever and JIA?
Ross River fever virus will cause a viral-induced arthritis, and historically when we look at serum of children who have juvenile arthritis, there are some viruses that come out as more common in the general population, including parvovirus B19 is more common in the oligo group. But in the main, if you have Ross River virus, you have a much more transient arthritis that should go. And
given that JIA is potentially a lifelong condition, a chronic disease you have to live with or think about forever, isn't there an absence of any known infection in JIA?
Yeah, I think what they're talking about an infectious trigger and then the disease persisting.
Yeah, right.
And that
I think it's important to say that Ross River is in the differential diagnosis of an acute child with painful joints. So it's something that you may have to rule out to come to the diagnosis of JIA.
Much like acute rheumatic fever.
Correct.
Right. Now let's talk about some non-pharmacological interventions for JIA, which includes going to camp. Arthritis New South Wales runs a terrific camp called Camp Footloose. It's an annual camp run for children between the ages of 8 and 18 with all forms of arthritis. This case study highlights many of the guideline recommendations in terms of support, education and physical activity.
The kids here understand what it's like to have arthritis, and it's really good because you say if you're sore, they won't argue with you about it. Yeah. And just talking to kids about it, they know what's happening, and it's just a great place.
Camp Footloose is a camp for children aged between 8 and 18 with juvenile idiopathic arthritis, and it's an opportunity for them to come to many of the same spots that they come to for school camps, but with a much more supported atmosphere. And instead of having 2 teachers to 40 students, we've got 1 leader to 3 campers here, so they've got more of an opportunity to do the activities because they've got that support.
Thanks guys.
The student leaders are students at university studying physiotherapy or occupational therapy. We also have peer leaders who are kids that have come to camp previously and got so much out of it that they want to keep coming back and give something back because it's been a huge difference in their lives.
Because I was a child here for myself, I know what the kids are going through. I've been through the experience. I'm still going through it. And if they have a problem or anything, sometimes they don't feel comfortable going up to the leaders who might not have arthritis or stuff. So they find it easier to talk to someone who's actually going through the same situation than someone who's not.
The aims of Camp Footloose are to promote independence, to increase the child's awareness of arthritis and look at it in a more positive light. The aim is to also reduce isolation as well as an opportunity for them to push their limits.
The first camp I went to was pretty much a brand new experience for me. Like going on school camps, see like a rock climbing wall or something, it's like, oh, no way I can do that. But here, they're more supportive, and it doesn't matter if you get to the top because everyone's behind you, and it doesn't matter what everyone else does, it's what you can do yourself. So I think the camp has like made an effect on me because it's just more like achieving my personal best, and I think that's the best part about it.
How do you reckon you're going to go?
Bad.
No, you're going to go good. As long as you try, you're doing good already.
Hey, wait, pull yourself up.
Come on, Amy. Push up, baby. Yellow one above it.
Ready? 1, 2, 3. You're not going anywhere yet.
Hey, you go too fast.
Yeah, you're all right. We'll take it at your pace. Right. We've got you. We've got you.
It's really good. You have a lot of assistance even though you're afraid to do it, but you just got to get in there and jump in.
Great work.
I feel pretty proud.
Physical activity is very important, but more important is the balance between rest and activity. With juvenile arthritis, about 70 to 80% will grow out of it when they reach adulthood, but what they won't grow out of is any disability that they have come across. So if they're not moving and keeping the joints active, then that can reduce their ability, and in the future that's where the disability comes from.
Did you make them up?
Today I was helping the kids do crafts. I guess the reason we do the craft activity is so that the kids who are having a bad day, they have the opportunity to actually come up and get a part of something else that may not necessarily be so strenuous on their joints.
You have the pain, the stiffness, and on top of that is fatigue, which to my mind is really a disease in and of itself. Because it's not like, I haven't slept, I'm tired. It's the all-encompassing, you can't lift your arm, you're so fatigued. And so that makes it difficult. And the fact that it is unpredictable, that one day they'll be fine, the next day they won't, which means people don't believe them. And for those in regional areas that don't get as much access, or, people, schools, healthcare professionals aren't as aware of it, they're not getting the services that those that are in city areas are necessarily getting.
Are you able to pull back?
Most people, when you talk about juvenile arthritis, they say no, children don't get arthritis. So I think the biggest thing is the ignorance and having to explain themselves. Not once, not twice, but every single time that it comes up.
I thought I was the only one at a young age who had it, but I came to camp and I met probably like 60 people my own age or even younger who have it. And when I went back to school after camp, I had more self-esteem and I could talk to people more. I found it a bit more easier to actually try and make friends, and yeah, I think it was just the whole communication, and I wasn't so much judging myself as much after that.
I got a Christmas card from a parent whose child came for the first time last year, and she was the child that, oh no, I can't do that because it will hurt, I can't do this, it will hurt, and now she's the one that says, okay, this is going to hurt, Mum, can you put an ice pack in the freezer, I'm going to give it a go. And the mother was saying I delivered home to her a completely different child who had gone from being reserved, didn't want to talk about her disability, to being out there and doing things and giving everything a go.
When I first got it was very down, it's very sad, so I missed having to give up like soccer, which was one of my favourite things at the time. But coming here like builds you up, like makes you feel on top of the world after achieving like all the activities, and like the leaders and other kids getting right behind you and supporting you makes you like feel a lot happier and better as a person.
What a wonderful camp to go to. Karen, tell us, how do we get to go to Camp Footloose?
Well, I get to go, which is wonderful. It's one of the more enjoyable parts of my job. Basically, you have to be a child to go with, unfortunately, with diagnosed arthritis, and to be aged between 8 and 18, because basically the activities are suited for that age group. And the benefit you really have just seen in that wonderful footage, Priscilla summed it up when she said that sometimes a child with juvenile arthritis can feel like the odd one out at school, but at Camp Footloose they all have some form of arthritis, so the activities are paced to suit the child. No one's rushed. The kids are quite happy for when they're climbing up the rope to wait. Everyone knows that they've got to go at their own pace, and there's also craft activities, as we saw. So yes, if people watching do have children with juvenile arthritis, they just need to contact our office and we can pass them on to the other states. I can give you a 1-800 number.
That'd be great.
Which which is 1800 011 041. And if they contact us in New South Wales, we'll pass on the details. Children come from all over Australia to that particular camp that you saw.
And how long does the camp last for?
It goes for just under a week, and we have between 40 and 50 children that
And where do you hold it?
We change the location every year because some of the children are repeat children and it can get a bit boring if you keep going back to the same place. That one was Dubbo, which was really exciting. The facilities were great. But this year we're going to a place called Milton Island, which is on the Hawkesbury River.
Fantastic. And do parents go?
Parents, unfortunately for New South Wales parents, well, for other parents, it is only for New South Wales parents, the sessions that we run. If parents wanted to come from interstate, they could also attend. But what we do is we run an education session for parents, usually at the beginning of the camp, quite often with a rheumatologist and other allied health staff, who'll do an education and awareness session for the parents while the children are sort of being loaded into the buses and off they go, because it's a nice diversion for them too, rather than saying goodbye to mum and dad if it's the first time they've been at camp. They get a sort of a quick goodbye, then they're whisked onto the bus and mum and dad get to participate in an education session.
Do you have any therapists attending as well, like Kerry and Penny, OTs, physios at the camp?
It varies each year. Yes, sometimes there will be therapists. There's always a nurse. We always have an on-site nurse because, as we've heard tonight, there's a lot of medications involved with juvenile arthritis, so the medicines are always administered by a registered nurse. But in terms of other staff, it varies from year to year.
Kerry, I wonder if we can go back to you. We haven't heard a lot about the role of exercise, but clearly it's an important part of the multidisciplinary care of the JIA patient. So can you tell us a little bit about what it is you do for your paediatric patients?
Yeah, I mean, as far as exercise, wherever possible, we want the children to just join in with regular physical activity and sport. Sometimes, as we've heard, there's pain and swelling in the joints. It is difficult, so my role often will be helping the children find a sport that they can do, modifying sports sometimes, so lighter bats and balls, for example, can be used if they've got sore wrists, things like that. So it's really looking at how they can be active, how they can join in at school, be part of everyday activity, modifying where necessary to allow that to happen. And
do you find that the children understand the role of the fatigue and how it might impact on their ability to exercise?
Yeah, that's always hard, and we work with schools as well. For example, it's often at school that it's a problem because it's a big day to get through at school. And so working with schools so they do understand that sometimes the children will have to rest. They may only be able to play half a game of the sport, or, you know, even during class time they might need some rest periods. So.
Actually, mentioning the schools, I might take that then to ask Penny a question about teachers and educating them. I see people you work with, which is Montrose Access, have put out this terrific guideline booklet for therapists, but I believe there's also some education for teachers, and people can access the services like yours through schools, is that right?
Yes, in the country areas or even in the cities in Queensland, they have therapists working in the schools, and they can ask for therapists to go and see the children. They don't do home visiting, they only see them in the schools, and it has to be school relative. But if there aren't any therapists, there's sometimes some therapists in the hospitals in the rural areas, and often they'll contact Montrose Access if we can go up and consult with them if they don't feel happy that they've got enough information, or if they don't know enough about it, and we can go out and visit the country areas.
So what sort of benefit would you provide to a school-age JIA patient? Things like the pens that you have there, would you like to show us some of these pens?
These are we suggest fatter tools for some of the students so that it's easier for them to hold, to put into to use when they're at school. These are triangular biros that push on and off. These are just, they're just pencils. I forget what the name is. And these are other ones as well with the rubber at the end, but they're just fatter and they're softer. And these are biros with the same sort of adapting things.
Are there any other problems that you would be seeing frequently in school-age children? I mean, you mentioned before not being able to get clothes on.
Many children need these sort of things, but the other thing, when children go swimming, some of these children with arthritis have difficulty changing their clothes independently, and they'll often need some help on ideas on how to do it more independently.
What are those ideas?
Sitting down to get dressed and undressed, wearing clothes that are a bit more loose. If they've got sore shoulders, then perhaps always having opening down the front type clothes, they can just drop off. Sometimes they might need help to put them on when their shoulders are sore. Not using t-shirts necessarily, because that's very hard for some children, put their arms up and through. But some children like to wear, if the uniform's a t-shirt, then if their hips are all right, they have tricks where they can go down and put their hands through the thing and pull it up that way. Oh. There are little tricks that you can do.
Fantastic.
I think some of it is maybe not knowing names or ways to access. The major children's teaching hospitals in all the states have at least the name of a paediatric rheumatologist either on site or able to be contacted via the hospital, and the various arthritis associations, including the Australian Rheumatology Association, has a Find a Rheumatologist website in which you can specifically go paediatric rheumatologist and it'll find someone with paediatric expertise.
But rheumatologist is a big word. Perhaps it's also just that people don't know that that's the kind of doctor they need to see. I wonder whether the arthritis associations in each state would play a role there too. Karen, do you?
We don't or couldn't really recommend to particular specialists, but we'll certainly steer people in the right direction about where they can find out that advice, absolutely, because parents can be groping around in the dark, sometimes trying to find that information. So we'll either speak to them or we'll send them material, whatever is meeting their needs, but we won't actually talk about specific doctors.
Now let's just talk quickly about long-term management and support of a JIA patient, and for that we have a case study of Amy, who is a 17-year-old girl living on a rural property 30 kilometres out of a town with her parents, 2 brothers and a sister. She was diagnosed with polyarticular RHF positive JIA at the age of 11. Her movements and physical ability are very restricted. She attends school but spends a lot of time avoiding physical activity and school excursions. Amy needs assistance with most activities and is due to have a knee replacement. So perhaps Penny, maybe I can ask you, do you see a role in long-term management for an OT like yourself?
At home?
Yeah, looking after a patient like Amy?
Yes, we'd go in and problem solve about what her issues are at home and how she can get around them and to keep her as independent as possible.
Probably forever, isn't it?
Yeah.
And Kerry, I mean, as a physio, is this the kind of patient that what sort of things would you do for Amy?
Well, trying to maximise her mobility as much as possible. So even though a child with severe deformity may need a wheelchair, trying to make sure that she is actually still able to get out of the wheelchair and walk as much as possible. If she's due for the knee replacement, finding a good local physio, because she's going to need to do a lot of work after the knee replacement to get back on her feet. So things like that. There'll be times when there'll be more need for therapy and then times when she's just going to be getting on with her everyday life.
And Karen, in terms of family and family support, what do you see are the issues when you've got a 17-year-old in a condition like this? What do they ask you at this stage?
They ask all sorts of things because they're also going through many other issues at that age. But basically, again, it comes back to they want to know about their prognosis, how they're going to develop. They will have lots of questions that any normal adolescent of that age will have, and sometimes these questions come up at Camp Footloose, and we would have trained people there to try and answer these because they're not always arthritis specific, but they might be about, will I be able to still do this, this and this, even though I have juvenile arthritis. So we're there to offer support and information to parents who might actually ring and ask us the same questions. They might know that it's bothering their child, and so they might ask the question on the child's behalf. So we're there to reassure, put them in touch with other parents, whatever it is they need, we'll try and assist.
I think another issue with her is she's on that transition between being a child and an adult, isn't she? And we have a question that's come in from an allied health professional and mum who's asked whether steroid medication would have an impact on the reproductive health of teenage females. Jeff, could you answer that, please?
Yeah, a question that's frequently asked of adolescent females particularly, and the drugs that are used in juvenile arthritis, including methotrexate as an immunosuppressive, and steroids, the long-term effects of that. I think the data is very reassuring, particularly methotrexate. The advice is obviously to stop the methotrexate before you considering conceiving a child for at least 3 cycles beforehand, and also for male partners to not be taking methotrexate at the time of conception. But listening to those sort of cautionary words has resulted in completely normal pregnancies, not very different from the population incidence in young women with juvenile onset arthritis who've taken methotrexate for years and years and years, and they conceive normal healthy babies. So you can reassure that mother that the prime aim at the moment is get good disease control, get a healthy young adult, and then her chance of conceiving is much better.
That's really the point, isn't it? That methotrexate is very well tolerated, much better tolerated than it looks on a piece of paper, because it's not a very pretty drug on paper, is it?
Yeah, unfortunately we tarred with the oncology brush where it's used in high doses for chemotherapy, and that's very different from rheumatologic doses, which are very spared of side effects other than mouth ulcers and nausea, and those can be eliminated almost by taking supplementary folic acid.
That's actually another question that I've had from a pharmacist in Queensland was, what is the dose of folic acid in a child on methotrexate?
The most commonly used dose would be 5 milligrams once a week, not given on the day that they take their methotrexate, but people would sometimes use 0.5 or 1 milligram every day other than the methotrexate day. Those regimens haven't really been head-to-head studied, but both would be effective.
Okay. We also have two questions about complementary medicines, and I guess this comes up a lot with long-term management, doesn't it? That when dealing with a chronic disease, people want to explore alternative therapies. One question from Elizabeth in Victoria asking about the use of copper bracelets, and a question from a physio in New South Wales about acupuncture. Perhaps I can ask Morton to comment on the copper bracelets, given that the guidelines looked at complementary medicines in general.
Yeah, I think we have to be clear that the guidelines are looking at whether they're going to modify the disease process. And there's absolutely no evidence at this point in time that complementary therapies actually alter the disease process. And I think copper is one of those. Now again, there isn't a lot of scientific evidence out there that can be reproduced and looked at in a systematic way. It's not to say that into the future there may be, but at the moment there isn't.
And do we have any information on the role of acupuncture for pain relief in JIA?
I think the answer there is that, again, for modification of the disease there isn't.
Yes.
But acupuncture certainly does have a role in pain management. There are good studies these days that show it can be effective, but it doesn't work for everybody.
So I think we need to just quickly talk about how the face of JIA is changing so much now that we use these modern medicines. So these questions allude to that it's not really just about pain relief anymore. We want to stop the disease process, and that's what these fancy biological agents do. So Jeff, just quickly, could you talk about which monoclonal antibodies are anti-TNF drugs are available for use in children and how well they're working?
Sure. The only TNF-alpha inhibitor approved for juvenile arthritis, so these are cytokine-targeted biologic molecules that stop the inflammatory process, is etanercept, and that has proven very effective. Prescribing is restricted to paediatric rheumatologists because of the expense of the drug, and once the children have failed methotrexate or another disease-modifying drug, or if they can't tolerate it. The other TNF-alpha inhibitors, like infliximab or Remicade, is approved for Crohn's disease, where it controls the bowel disease and also helps the arthritis, but it's not primarily approved for juvenile arthritis. In other words, it's not funded by the PBS for that condition. If
they go on etanercept, do they still stay on the methotrexate?
Most of the data would say that methotrexate and etanercept together are better than etanercept alone. Some patients who are having methotrexate side effects may choose to stop it because of the nausea and still be in remission on etanercept alone, but ideally both are used together at the start. And so would you like to briefly just comment on the long-term issues of side effects with these medicines, methotrexate in particular, and the monoclonal antibodies? What side effects should people be looking out for? So methotrexate, nausea, mouth ulcers, monitoring liver function tests maybe 3 or 4 times a year is now adequate, and looking for anemia and low white cell counts, none of which have proved to be a clinical problem, and being cautious with varicella. Children will get very serious varicella if they're on methotrexate. It needs to be stopped, or ideally they should be immunised against it before starting it. The TNF-alpha inhibitors, there has been an a cautionary warning from the FDA about an increased incidence in Crohn's children on infliximab getting a rare type of lymphoma called hepatic lymphoma that's currently being looked at. At the moment it's a black box warning without any very strong statistical data to support it.
And do you think there's any risk of malignancy with the TNF inhibitors?
There's now a biologic registry worldwide, and that data is being looked at prospectively. If the risk is increased, it's not substantially increased.
And what about tuberculosis? Do you do mandatory tests?
So the adults, mandatory because of occult or hidden or quiescent TB, have TB testing. In fact, all children should also be tested for tuberculosis before starting TNF-alpha inhibitors, although the incidence of occult TB in childhood is very low in our population group.
Okay, so with your JIA patients, what's your approach to multidisciplinary care?
I follow the guidelines implicitly.
Of course.
Yes. Okay.
Do you prescribe a physio and prescribe an OT?
So there are some children who have quite mild disease where it's easy to inject them and they run around normally and they don't need the ancillary support. Certainly for the children with more severe disease, they need the physio, they need the OT, they may need a social worker, they need support groups, they certainly need an ophthalmologist to check them regularly, and they need their local general practitioner to be involved in all their interim care.
Thank you. We've covered a lot of ground tonight, so I wonder if I can ask each one of you for a take-home message, please. So, Kerry.
I'll get to go first. Keeping physically active and being able to participate in physical activity, I think, is my main
No role for bed
goal.
rest?
No role for bed rest, definitely not.
Karen, your point, please?
Early diagnosis is the most important thing, but don't forget that parents will be worried and anxious, so refer them on to someone like us who can calm them down.
Penny?
Always aim for independence, to keep them as independent as possible and to believe that they can be.
Jeff?
Kids get arthritis too. Don't attribute the swollen joint to some minor trauma that no one saw, or some meniscal tear which doesn't really occur in 2 or 3-year-olds. Think of inflammatory disease when the joints are stiff and swollen.
Morton?
I think I'd say make sure that you remember that JIA does exist and it does present in general practice, and it's a disease that you can markedly change the outcome if you pick it up.
Fantastic. Okay, well, I'd now like to thank the Department of Health and Ageing for making the program possible tonight, and thanks also to you for taking the time to attend and to contribute. If you're interested in obtaining more information about the issues raised in the program, there are a number of resources available on the Rural Health Education Foundation website. That's rhef.com.au. And don't forget to register for CPD points, so please complete and send in your evaluation forms. I'm Geraldine Moses. Good night.